All right, so happy Valentine's Day, everyone. So I'm gonna get started. The topic I've chosen today, I've decided to entitle it Choosing Wisely in Nephrology. This is not something I created. This is actually the title of an initiative from ABIM that is supported by 80 medical societies, kind of uniformly, that has as its mission to encourage a national dialogue between providers and patients about optimizing necessary testing against unnecessary testing, minimizing costs, minimizing harm. And that's the purpose of this campaign, is to sort of identify areas in medicine in which we are doing things that aren't necessarily leading to anything good for patients, and then to encourage that conversation with the patients. And I really like the message of this, and I sort of was inspired to do this. I was inspired to do this actually because I work with Theo, and I work with the medical students at the Equal Access Clinic. Some of the fellows have joined us there. And this is a clinic that provides free care to patients in the community. And particularly I work at the Monday night, the Spanish night, and we've started a nephrology night there once every 2 months, where we provide care, nephrology specialty care. And I had a patient come into clinic with this story. I was volunteering at this clinic, a 35-year-old male who'd recently immigrated to the US from Central America. At a recent health fair, routine basic metabolic panel found his creatinine to be 2. This was repeated before your visit today and is 2.1. He tells you he has never had kidney disease, he has no hypertension or diabetes, he takes no medications. You would like to order testing to evaluate his CKD. However, the clinic, this is a free clinic, they have a budget, right? And their budget is $90 to spend on all the 20 patients that are in clinic that day. So that leaves about $5 that I could spend to order labs for this patient. So the question that I was left thinking about, okay, I'm in a situation where I need to evaluate CKD in this gentleman. What is the most parsimonious, high yield panel of laboratory tests I'll order for this patient, right? To sort of optimize getting the information I want, but spending the least amount of money and considering my restraints, right? And it caused me to think on a broader scale about what we do in clinic, right? We have patients referred to Shands of the VA for CKD evaluation. They all come in with a renal panel, CBC, urine protein assessment, urinalysis, SFAT, UPEP, HIV. So it is something we need to be doing with these people. And so this was sort of the impetus for this talk, with this case. And so the objectives of this talk, briefly in the beginning, we're going to discuss and consider the idea of value in healthcare, and understand how value in care is measured and applied. And so, I mean, these are huge topics that could have a whole grand round on its own, but I wanted that to be sort of a springboard for us to really spend time to go through some real world examples of common diagnostic and therapeutic care measures that we do on a regular basis in nephrology that maybe we should reconsider. So I'll do this in a case-based format. I'll present a case similar to what I just did. I'll pose a question. I will then present some data or some literature that speaks to this question that I've asked, but I'm not going to provide definitive conclusions at the end, just a spoiler alert for you. So I don't want you to be disappointed, because a lot of these questions are not questions that have firm answers, all right? But the purpose of this talk is really to just stimulate thought, stimulate discussion. So value in care. What do we mean about value in care? So this came up, I actually put this question out on the ASN Digest because I was just curious, what do people view as, low value things that we do in nephrology, things that we should reconsider? And so this question of, value at the population level versus the individual patient level came up, right? At the population level, we're talking about the greatest good for the greatest number of people, hitting high yield diseases, that affect a lot of people, right? Optimizing costs on a large scale. Versus the patient who's sitting in front of you. You've got these sort of guidelines on what works sort of at the population level, but does this necessarily apply for your individual patient? I think those are two related but also separate questions. At the population level, we have organizations like the US Preventive Task Force, for example, that puts out screening guidelines for things like breast cancer, colon cancer, lung cancer, right? And so they will look at the existing evidence, weigh the benefits of screening, for instance, and then treatment and its effect on clinical outcomes, come up with a number needed to screen or treat, think about the public health burden that we're addressing. Is this something that's significant enough that it's worthwhile to address? And they'll weigh that against the cost associated with screening, the cost associated with treatment, the harm that might come from incidental findings, unnecessary procedures that result from those incidental findings, and adverse events that occur at any path along the way, the number needed to harm. And so if you look here, this is an example from US Preventive Task Force approach to looking at low dose CT for lung cancer screening, which is now a recommendation in high risk groups to do every 2 years. And so they put out a research plan, and they do the similar flow for sort of any sort of look at screening. They identify adults at risk, they identify screening tools, how well do they work for detection of nodules, then diagnosis of cancer, and then identifying treatments that might prevent progression to advanced disease, and ultimately key outcomes that we care about. So these blue dots represent the preventive task force looking at questions about efficacy, looking at discrimination of these screening tests, looking at the magnitude of impact at each of these junctures. But in counterbalance to that, you have these orange dots, which are questions at each juncture about harm, right? Questions about the harms of screening, harms of workup or surveillance, the harms of treatment, and they try to balance these. And so for lung cancer screening, the number needed to screen was 130 to prevent one lung cancer death over 10 years in high-risk patients, a certain subset, right? Balanced the number needed to harm of 59, which seems pretty low to me, for false positives leading to invasive procedures, associated costs and stress was considered, and ultimately the recommendation was made for screening in a subset of individuals. But at the end of the day, you have your patient sitting in front of you, and this may not necessarily apply to them. Maybe they're in this high-risk category, but they've experienced, they have other circumstances in their life that obviate the need for this screening. And so what I like about the choosing wisely sort of mantra, that you'll see there are other sort of offshoots of this, things we do for no reason, for example. I don't like that terminology because I don't think in medicine, we really, as physicians, do things for no reason. It may not be the right reason, it may not be a randomized trial, right? But there's a reason that we're doing it, right? It might be anecdotal, information. And I like that the choosing wisely sort of combines an understanding of the need to look at population level data, but also have a conversation with the patient. So let's go back to this case as a springboard for now the series of cases we're going to go over. My patient that I saw at the Equal Access Clinic, what is the most parsimonious high yield panel of laboratory tests you might order in this patient? And so, when I looked at the cost of all the labs that the Equal Access Clinic would incur, when I ordered, just getting a renal panel will obliterate his budget. Now, maybe other people at the clinic don't need anything, so we could get a few other things, but other tests that we would get, urine albumin to creatinine ratio, checking an HIV in this young guy, right? Checking a hepatitis panel will really break the bank. So what is sort of the most parsimonious, what is the most high yield diagnostics in the evaluation of CKD? So again, there's not a lot of great high level data in this, and I think their data will be forthcoming. But this is a study that was published in JAMA IM in 2015, and these guys looked at the usefulness of diagnostic evidence in the initial evaluation of CKD. And what they did was, they did a retrospective cohort study. These are two centers kind of within the same institution. And they looked at over 1,400 referrals for CKD evaluation. So these are first referrals for CKD. And they manually chart reviewed to extract what diagnostic testing was done and to determine the yield on that testing. Did it change our diagnosis? Did it change our management? And so this is subjective, right? These are two nephrologists that were doing this extraction, so it's subject to that bias, right? Notably, most of these people had stage 3B or better function, and 42% had proteinuria. So this is what they found. So these are the urine tests, the serum tests, and imaging. And this is not an exhaustive list. I kind of put the most common things that would be familiar to us. This is the frequency with which it was ordered, so the N and the percent. And so you can look to see kind of, is this in line kind of with what you do in your practice? And do you order this frequently? And then of these, what proportion had an abnormal result? And what proportion of these affected diagnosis and what affected management? And you can see here that really only the urinary protein excretion affected over 1 in 10. So I think that's reasonable, right? The A1C was important here. But by and large, everything else affected diagnostics or management in less than 3% of patients, except for renal ultrasound affected diagnostics in about 6%. So again, what does this mean? Does this mean I shouldn't be ordering SPEPs and UPEPs on my CKD patients? Maybe not, right? Maybe not. This doesn't tell me about the harm of missing a paraproteinemia, right? In a patient that I didn't get an SPEP and UPEP. I can't answer that question. But I do think it's food for thought that we should maybe pause and think about starting with a more parsimonious panel and then evolving what we order based on how things develop. So something that's coming down the road, yes.
I'm so sorry. Can you go back? So I think the point is fantastic. So one question that what's the relative harm of missing? And you say, right?
Absolutely.
And so missing an SPEP at, let's say, 1.4% of a diagnosis of myeloma, that has a life-threatening implication compared to, let's say, that dipstick of 1.8,
Right.
where it might decide whether it's between diabetic nephropathy or IgA nephropathy.
Right.
You see my point? Like, so I think there is a value that there as well, which they can't eventually.
They can't quantitate. And again, I think that's where the, population level recommendations for screening in CKD probably wouldn't say everybody needs an SPEP, right? But there may be subsets of higher risk populations that need that, so that you take a targeted approach. And so the US Burn of Task Force actually has released a research plan for them to develop screening guidelines for chronic kidney disease. And the research plan is published in 2023, and they're working on it apparently. And this is sort of the flow of how they're thinking about things. So they're studying adults, and they're looking at two groups. So people who have stage 1 to 3 CKD without known CKD or risk factors, so trying to screen for stage 1 to 3 CKD, and then screening in folks who already have detected CKD or who are at high risk. How often should we be following them, et cetera. And they want to look at various factors. They want to look at the role of estimated GFR, albuminuria in screening, and they want to look at ultimately the downstream medical interventions that come from that screening, and they're looking at all of the medical interventions. I mean, they list them all, everything we have trials for. Blood pressure targets, intensive versus less intensive treatment, DASH diet. And they want to look at ultimately downstream of this screening, leading to interventions, leading to outcomes. And from that, make recommendations on screening and frequency of follow-up in CKD. So I think this is interesting and is coming down the line. I don't know if it's going to answer all our questions, but it's something. So I have now selected topics, and again, these topics are topics that came from talking to colleagues. Again, things that there were just 3 or 4 topics that recirculated on the ASN Digest. So I am presenting kind of those things that were brought up. Again, I'm not going to have conclusions for you. I'm not going to have a slide at the end that says, don't order this or don't, because none of these come with data that's definitive enough to say that. All right, you're rounding with a renal fellow in the hospital. An ESRD patient is hospitalized with failure to thrive and workup is ongoing. You're reviewing labs, and the fellow notes that total calcium level is normal at 10, but serum albumin is 2.0, such that the corrected calcium is 11.6 milligrams per deciliter. ETH is within the 2 to 9 times the upper limit of normal of the lab. The fellow would like to hold activated vitamin D in the setting of hypercalcemia. Should action be taken on this corrected calcium level? So corrected calcium has made it to the things we do for no reason under choosing wisely. And again, I don't like this things we do for no reason. I think it's so dismissive of the fact that we all really consider carefully what we do. Again, it may not be coming from a trial. But so where is all this coming from? So calcium distribution in plasma. We know in normal calcemia, calcium is 40% bound to albumin, a little bit bound to other anions, and then 45% is ionized or free. And this is what the tissues sense and what the tissues regulate, right? And so in hypoalbuminemia, there's less binding sites for calcium on albumin, right? And so you may think this would shunt to the ionized, but of course this gets managed very quickly, and this stays the same. With the drop in albumin, less binding sites, the total calcium decreases. So you'll have a low total calcium but an ionized will be normal in theory. And so because of this, investigators have developed formula to adjust for calcium, for hypoalbuminemia and calcium, and correct the calcium for hypoalbuminemia. So this is the original paper by Payne in 1973, where he developed what would eventually become this formula for corrected calcium that most people use. And I had never read this paper before, actually. It was, first of all, it had some big problems. It was a small sample, 200 consecutive specimens sent to the lab for albumin measurements, and they ordered total calciums on everyone. And then they used the wrong gold standard. They think of this corrected calcium as a way to sort of reflect ionized calcium, right? If we correct this, it's normal, ionized is normal. What they did was they developed this formula to target the median normal total calcium range for their lab. Okay, they did not predict ionized calcium. And so downstream of this, there have been problems with this corrected calcium's performance to predict ionized calcium. I want this to go away. How do I go?
The top right click and then that one.
Thank you. All right, so this was a retrospective cohort study at a single center in Norway. And they looked at the performance of just not correcting the total calcium, using existing formula, including this Payne formula and a new formula they developed to predict ionized calcium. And they looked at the performance by eGFR level and by ionized calcium level. And this is the characteristics of the cohort. Most were outpatient, subset were inpatient. The inpatients had lower albumin, lower GFR. And so what they found was, when they looked at the agreement between the total calcium and the ionized calcium, looking at the AUC, right? This is the area under the curve. These are values that reflect how well the total calcium predicts the ionized calcium. The closer you are to 1, the better you perform. 0.7 to 0.8 is considered to be a reasonable AUC for performance. This is no correction, and these are the different formulas, including the Payne one that we commonly use. And this is preserved kidney function, reduced GFR. And you can see that across the board, the AUCs are pretty similar, but notably, no correction performs similar or better than most of these formula. And then when they looked at the performance of these formula now by GFR, so normal GFR, reduced GFR, across a hypocalcemia range. This is low ionized calcium. You can see this is the AUC kind of across that, even though it's variable across levels of calcium, in general, the AUC is fairly preserved. And the black line here is no correction. And even in reduced GFR, the black line sort of outperforms the other formula.
Excuse me, did they check for acidity? or
Yeah,
pH?
this is that pH of 4.0.
All of them same
Mhm,
way.
mhm. And so then when they looked at hypercalcemia, you can see here that the AUC sort of changes depending on the calcium level. And this looks pretty dramatic, but you're going from an AUC of like 0.85 to 0.95 here. I mean, still acceptable performance, but definitely a trend. And no correction is sort of performing in the middle of the pack compared to the correction formula. And so, but what about the albumin level? There's some evidence that the albumin level may be important for the performance of these formulas. So this was a retrospective cohort study, single center, 5,000 hospitalized patients, ionized calcium, total calcium, and albumin reported at the same time. And they looked at the impact of the serum albumin on the relationship between corrected calcium and ionized calcium. And so here is this figure that shows the spectrum of albumin levels. And this is the difference between the corrected calcium and the ionized calcium. So with this formula, we would expect this difference to stay stable across albumin levels. So we would expect this line to be straight here. But you can see that when you get below an albumin level of 3, that this difference starts to increase, suggesting that something's different at lower albumin levels. And it may be that there is differential binding of calcium to albumin at lower albumin levels, such that binding is increased at lower albumin levels. So this was a very small, I wouldn't call it the highest quality study, but a very small study of 30 patients who had a spectrum of hypoalbuminemia. So this is mean albumin for this group here, 1.75 all the way up to 3.0 for the overall hypoalbuminic. And they looked at the approximate binding constant of calcium to protein, with hoping that protein is reflecting albumin as well. And they found that the binding constant was higher at lower albumin compared to higher albumin. So. Okay, so what do we do about this? I mean, I still, when we do our monthly dialysis meetings at the VA, you know, all they care about is what's the total calcium level in the patient, right? I mean, our total calcium is what we report in dialysis, it's what we're measured on, right? What do we do with this data? What does it mean, or what are the implications of missing, a low ionized calcium, for instance? So this is a study that looked at this concept of hidden hypocalcemia and risk of cardiovascular events and mortality in dialysis patients. So this was a retrospective cohort in Japan, 336 incident dialysis patients over an 8-year period. And they looked at the impact of having a hidden hypocalcemia, which is basically your corrected calcium looks normal, but your ionized is low. And they looked at the impact of this on outcomes over a median of about 25 months. And so if you look here, this is how they grouped people. This is the corrected calcium, low, normal, high. And this is the ionized calcium, low, normal, high. So this is the scatter plot of these patients here. And you can see that very few people had, true hypercalcemia or hidden hypercalcemia. A good chunk had normal calcemia by corrected and ionized, and apparent hypocalcemia, low corrected and low ionized, okay? But look, 46% had a normal corrected calcium, but a low ionized calcium. And so they looked to see what are the outcomes of these groups of patients. And so this is a 2x2 table, normal calcium, low calcium corrected, normal, low ionized. And when they compared to dialysis patients who had normal in both categories, those who had hidden hypercalcemia had a 2.8-fold greater risk of cardiovascular events and mortality after a multivariate adjustment, suggesting that this is an important entity that may be common and that we need to think about. And so even though our KDIGO guidelines don't speak to getting an ionized calcium in our dialysis patients, in this controversies conference that came out commenting on the mineral and bone disorder guidelines, they recommend that the future work group should consider whether to recommend ionized calcium in the blood. Anybody else need to scan here? You're seeing a 67-year-old patient with diabetes, hypertension, and stage G2A2 CKD. Blood pressure on home readings range from 140 to 155 over 70 to 80. You recommend initiation of lisinopril 10 milligrams per day as a new medication for this patient. The most recent potassium level is 4. Should this patient have a basic metabolic panel drawn and follow-up of RAS inhibition initiation? So this seems like a very low yield question, right? I mean, who cares? It's just a BNP, right? But in my patient equal access clinic, I face this all the time. I can't bring these patients back and get labs that frequently. I just can't, And so what's the harm in that, right? Do I have to do it? The KDIGO guidelines for management of diabetic kidney disease and for management of hypertension and CKD uniformly recommend after you initiate ACE or ARB that in 2 to 4 weeks after starting, you need to check your creatinine and potassium to look for a rising creatinine above what's acceptable and hyperkalemia. So, but do we have to do this? So this is a retrospective cohort study that looked at 2 groups, a big group from Kaiser Permanente that was younger and an older group in Canada. And they looked at new ACE or ARB dispensation date. And they first quantified the occurrence of a test for serum creatinine and potassium within 30 days. In the Kaiser cohort, about 26% had that checked. In Canada, about 30% had that checked. And they propensity matched those guys who got tested to a group of people who had ACE ARB dispensed but didn't get tested. And they propensity matched them on the things that might predict testing and predict any important outcomes they wanted to look at. Yeah.
Sorry, are those patients who did not get the test or when the test wasn't ordered for the patient?
Yeah, so that they do not have evidence of a test being done. So they don't speak to whether it was ordered or not.
Okay.
They just speak to whether there is presence of this lab. That's a great question. It's different. And so they use this to develop a risk prediction tool to predict who might develop hyperkalemia or elevated creatinine. And so this is the tool that they put out that you can get on QXMD that plugs in all these parameters here that might affect risk of having a rise in creatinine or hyperkalemia. A1C is decent for potassium, 0.75, a little less for creatinine. I plugged in the information for our guy. His risk of hyperkalemia is about 1% in the next 30 days. Risk of a creatinine increase that's too much is about 2%. Another group did something similar, is a Swedish healthcare utilization cohort. This time they matched new or increasing ACE or ARB dose with a patients who got started on a new beta blocker. So we have about 20,000 pairs that all had a recheck of potassium, at least one within a year. And these guys had largely preserved renal function, 25% with albuminuria. And what they found was the likelihood of having a potassium over 5.5 on a recheck within a year was pretty similar at preserved GFR. When you got below a GFR of 45, it was greater in those who had ACE or ARB and up to 30% in those with advanced CKD, which I think we kind of noticed. This isn't surprising. So they developed this risk score that had a little bit better performance, the C statistic, which is like the AUC of about 0.85, and included a kind of a more parsimonious group of risk factors that I think all make sense to us. And they validated in another cohort, US cohort, that's sicker, and his performance kind of stood up. So we have these tools, if you're stuck in a situation like me in equal access clinic, to be able to sort of assess risk of hyperkalemia. I think intuitively, we could all think of these risk factors on our own, however. All right, one of the house staff calls you to ask about a patient you consulted on in the hospital with AKI. The patient has diabetes, hypertension, and CAD and was admitted for sepsis related to an infected foot wound. They're preparing to discharge and want to know when they can restart the patient's lisinopril. Is there any rush to restart RAS blockade after AKI? Is a question. So this is a study that was done in the VA pretty recently. It was a retrospective cohort study of over 50,000 patients with diabetic kidney disease, so diabetes, CKD, and some proteinuria. And they looked at the timing of reinitiation of RAS blockade after AKI on mortality. And so this is just to give you a sense of what this cohort looked like as far as initiation of ACE, ARB, and recovery. At discharge, 40% of these guys that had AKI restarted their RAS blockade. And then progressively over the course of the next year, small amounts restarted. But at the end of follow-up, 30% never restarted their RAS blockade. As far as recovery was concerned, a very similar proportion that started RAS blockade had recovered function. And then by the end of follow-up, 23% had not recovered function. And this is what they found. So this is the outcome of mortality by timing of initiation of RAS blockade after AKI, taking into account AKI recovery and multiple other factors that might be affecting risk of death. And you can see here, this is the most adjusted model here, that at any time point, restarting RAS blockade after initiation, after AKI, has a mortality benefit. But that this mortality benefit is greater for earlier initiation, suggesting that the earlier we start RAS blockade, the better. And I think this is intuitive. And this is taken into account non-recovery status too. All right. During monthly outpatient dialysis rounds, your patient is found to have persistently high serum phos level of 6.7. He has known diabetes, hypertension, and peripheral vascular disease. He's been counseled several times over the past year regarding dietary restriction, and he's been non-adherent to myriad phosphate binders we've trialed. He tells you he's tired of a low phos diet and is willing to accept any risks associated with this hyperphosphatemia. Let me enjoy my life, he tells you. What is the benefit of lowering phosphate in dialysis patients? Is this a hill you want to die on? So phosphate and mortality in hemodialysis patients. So huge retrospective cohort study of 40,000 dialysis patients looking at their phos level and mortality up to 18 months of follow-up. And you can see here that after multivariate adjustment, including demographics and risk factors for death, that with rising phos levels, this rightmost bar, risk of death goes up. Okay, there's a hint of a U-shaped curve here as well, but definitively higher phos, more death. Okay. In CKD, before dialysis, a meta-analysis of 12 cohort studies showed, so on the right side here means lower FOS means better outcomes. And this is looking at CKD progression, but similar results have been found in for mortality. So the question is, does the corollary stand? And this is an age-old debate in nephrology. This is nothing new. There have been pro-con debates at ASN, as long as I can remember about this. FOS lowering in CKD. If higher FOS leads to bad things, does lowering FOS then mitigate those bad things? And the answer is there's no evidence of that today. And this literature has been plagued by really minimal placebo-controlled trials of phosphate lowering. There's this one lanthanum versus placebo looking at kind of surrogate cardiovascular outcomes that found no difference. But by and large, and these are sort of the most recent trials, there have been many more, most of the trials are comparing two different phosphate binders, making it challenging really to show that the phosphate binder is better than placebo, right? And so this literature has really been limited by this. And KDIGO over time has sort of softened its language, although not definitively in a helpful way, to in 2009 saying we suggest using phosphate binding agents in the treatment of hyperphosphatemia. Decisions about phosphate lowering treatment should be based on progressively or persistently elevated serum phosphate without really saying lower it this way or that way. And the rationale here for using the broader term is that instead of all phosphate binding agents, because all possible approaches may be effective, I think is sort of an indirect nod to the lack of evidence of benefit. But moving forward, there is this trial coming, the HELO trial. It's a pragmatic randomized trial of phosphate management for patients on maintenance dialysis. And they're looking at over 4,000 dialysis patients across multiple dialysis centers in the US. And they are not randomizing to a binder or not. They are randomizing to a target FOS group. So they're really answering the question, what is the right FOS level we should be targeting? And so one group will be high phosphate target, one will be low phosphate target. They'll follow for up to 45 months and look at outcomes like cardiovascular events, mortality, and quality of life, you name it. So hopefully this will provide some meaningful results. You are consulting on an 83-year-old man with known CKD4, baseline serum creatinine about 3.7, diabetes, heart failure, hypertension, and history of stroke. He's hospitalized for fatigue, excessive sleepiness, and failure to thrive, found to have an acute on chronic kidney disease versus progression of his CKD with serum creatinine now at about 6. At baseline, he's mostly sedentary, recently moved to a nursing home due to inability to care for himself. He's still mentating well. We discussed dialysis with him, and he expresses a strong desire to live as long as he can, as long as his quality of life can be preserved. He says he does not want to be in and out of hospitals. Will initiation of dialysis meet this patient's goal for care? So this is a conversation we have a lot, particularly at the VA all the time, right? And it's a tough conversation, but what data do we have to help support these conversations? And so this is a nice study that came out last year using VA data. And they looked at the effect of starting dialysis versus continuing medical management in folks who are at dialysis door and older adults. And so it was a retrospective cohort study. They did a sort of a target trial emulation, which is sort of a more novel, sexy way we make retrospective studies be a little bit more valid. And they emulated a hypothetical trial of veterans with an eGFR less than 12 who were not referred for transplant, okay? And they randomized them, this trial would randomize, this is a retrospective cohort study. This trial would randomize them to either initiation of dialysis within 30 days or medical management. Medical management meaning dialysis was not started within 30 days. It doesn't mean that that group couldn't possibly get dialysis down the road, okay? And the outcomes were survival and cumulative home time. And they followed the patients until they died or until the 3-year mark, okay? And this is sort of what the cohort looked like. So the medical management group versus the dialysis group. And this is the standard difference. So this is, they did something called inverse probability of treatment weighting, which is in the same category as propensity matching to deal with confounding by indication, right? Because people who get assigned to dialysis, this is a retrospective study, it's not really a trial, So people who got dialysis may be different in important ways from people who didn't get dialysis for the outcomes we're considering, right? So this inverse probability of treatment weighting sort of mimics like propensity scores essentially. And so after weighting, you can see that the difference between groups is minimized, but it is an older cohort here. Median time to start dialysis in the medical managed group was 3 years, and it was 8 days in the dialysis group. And mean eGFR was 9.6 in the medical management group, 8.3 in the dialysis group. They brought these closer together after weighting. Rate of decline was a little bit faster in the dialysis group. And so this is the, the simplified version of the data, which I think is the easiest to digest. So this is all patients. This is patients starting dialysis and continuing management. The blue here represents days at home dialysis free, okay? So if you were on dialysis, let's say you're in the dialysis arm, they counted out of every week, 4 of those days counted toward days at home. And 3 of those days counted toward days on dialysis, okay? And then white is days spent inpatient or in a nursing facility, okay? And you can see here that comparing for all comers, starting dialysis versus continuing medical management, this was about an average of 9 days difference in survival. But those who continued medical management had many more days at home, less days on dialysis, and less days in the hospital, okay? And this was largely driven by what we saw in the age group of 65 to 69. In fact, these guys, continuing medical management translated to about 18 more days of survival, and more days at home, less days on dialysis, and a couple more days in the hospital or nursing facility. And then we look in the category of our patient, over 80. So continuing medical management did translate to lower survival, the difference of about 60 days. However, these guys had much more time at home, much less time on dialysis, and definitively less time inpatient or nursing homes. And I think all this is relevant coupled with what we know about what happens to functional status when we dialyze older people who are in nursing homes. So this was a retrospective cohort study that looked at the USRDS minimum data set, so registry of nursing home residents in the US. And they looked at folks who initiated dialysis over a couple year period. They looked at about 3,700 that had functional status assessment at baseline. And they looked after they started dialysis at what happened with mortality, when did they die, and what happened to their functional status. And you can see here at the 3-month mark already, 30% died. Another 40% had a decline in their functional status, right? So you've got here over 60, 65% that have had a sort of a negative outcome just within 3 months of starting dialysis, right? And then by 6 months, half of these people have died. And then add a couple of that with the reduced functional status, you're at 75% having sort of a negative outcome. And in 1 year, almost 90% have died or had reduction in functional status. So all this stuff is fertile kind of information for conversations with our older adults who want to start dialysis.
Can I ask a quick question?
Yeah.
Choose one more slide back. Yes, on this one.
Yeah.
I think it kind of goes along with what we oftentimes think, with quality of life versus quantity.
Yeah.
But did they assess the subjective quality of life assessment from the patients in each of the groups in the study?
They didn't have, this was a retrospective study of over, I think the sample size was huge, and so this is all just retrospective data. They didn't have quality of life measures, but they did in this nursing home study. This it's not really quality of life. This was functional status per se. I mean, that is a component of quality of life, but it is not a formal quality of life assessment.
Right. So my question is there quality of life being longer at home, or without dialysis, or there more quality of life being at home on dialysis?
Right. And so that's an
dialysis.
important question. That's an important question. Absolutely. All right, you were asked to see a 56-year-old female with well-controlled hypertension, admitted with lobar pneumonia and sepsis. She's anuric for the past 12 hours. In making a plan for evaluation and treatment of this patient's AKI, your fellow recommends a renal ultrasound. What is the yield of a renal ultrasound and AKI, and should all patients presenting with AKI have a renal ultrasound? So this made it to the things we do for no reason again. And so why did it make it here? So this is a study that attempted to look at risk stratification to identify who needs a renal ultrasound presenting with AKI. So it was just one institution, cross-sectional study. They had a derivation sample. They basically looked through all the ultrasound studies over 2 years. They selected one study per patient until they had 100 studies that had hydronephrosis and 100 without. So they had 200 for the derivation cohort, and then they used the prediction models to predict likelihood of having hydronephrosis on an ultrasound. And then they validated that in a validation cohort of 797 people. And here's what they found. In their final model, the factors that associated with increased risk of hydronephrosis on an ultrasound, obviously history of hydronephrosis, recurrent UTI, adults, bless you, consistent with possible obstruction, non-Black race, and bless you, Dave, sorry. And the absence of another explanation for the AKI, right? Nephrotoxic meds, heart failure, renal AKI. And the statistic for the performance of this prediction model was about 0.8, which is pretty good. And they divided them into 3 risk groups: low, less than 2 points, medium 3 points, high, greater than 3 points. And when they looked at the performance of this model, so there's 2 models here, they both have the same parameters in them. The only difference is model 2 has a slightly different definition of pre-renal AKI, but this is the main model that they tested. To me, the most important thing here is a negative predictive value of a low probability score. So having less than 2 points means you're 97% certain that there's no hydronephrosis in this, that this ultrasound is not going to yield hydronephrosis. And they looked at a more kind of stringent outcome, hydronephrosis requiring intervention, okay? And the negative predictive value of low risk on this scale was 99.6, so pretty high. So put another way, you can see here, this is low risk on their scale, medium and high risk. And this is the proportion that had hydronephrosis was 3% in the low risk, as opposed to 11% and nearly 18% in the high risk. And hydronephrosis requiring intervention, even lower. So you might be asking yourself, who cares? I mean, it's a renal ultrasound. It's so low risk. I mean, how much can it cost? You know, you really have to think about every little thing, right? And also like we've talked about in other situations, what is the potential harm of missing hydronephrosis, right? In those 3% of patients, right? I can't answer that latter question for you, but this group did try to get a little bit at cost associated. So if you look here, this is the number needed to screen. In the low risk group, you would need to screen about 33 patients, get 33 ultrasounds to detect 1 hydronephrosis, okay? To detect 1 hydronephrosis requiring intervention, you would need about 225, okay? And the cost of those 225 ultrasounds is about $40,000. The cost of getting 33 ultrasounds is a little over $6,000, okay? So, you know, the cost benefit here, you know, is there for you to consider. However, in the medium and high risk groups, you can see here, you need to screen very few to capture hydronephrosis. So the cost associated with that is much lower, right? Food for thought. Maybe we don't need to get renal ultrasounds in everyone. So I think most of us feel that way, right? You can always reserve the right to get it later if you need it. All right, last case, I had to throw something transplant in there. So you referred your 61-year-old dialysis patient for transplant evaluation. He's been on dialysis for 5 years, and comorbid conditions include diabetes and hypertension. He has good functional status, performs all ADLs, is able to walk around his block with no limitation. He's up to date on all age-appropriate cancer screening. He underwent MPS under the direction of the transplant team and was found to have a moderate-sized reversible defect. The transplant team is requesting a left heart cath with intervention. Is there any evidence to support this recommendation? So if I get this wrong, transplant people, you let me know. I mean, this really just chops my hide. I mean, at the VA, I cannot tell you how many of our vets are sent for revascularization.
I take it back, just to interrupt you. There is no evidence to do a nuclear medicine study if, first and foremost.
Absolutely, first and foremost.
You do an EKG and an echo. And if the echo is not suggestive of a previous MI
Yeah.
or coronary artery disease or EKG doesn't show a Q wave, which is the current guidance, you don't need a nuclear perfusion. study.
At the VA, if you had diabetes for more than 10 years,
Yeah.
you need a left heart cath.
Yeah,
And you can imagine our patients who are at dialysis door, waiting to get listed, right? We need to go have a left heart cath, and they feel fine, and they have no symptoms. So anyway, cardiac evaluation pre-kidney transplant. So screening for coronary heart disease and pre-transplant is common. Over 40% of transplant recipients had some sort of testing in the year prior to kidney transplantation. Large randomized trials recommend against screening in asymptomatic patients, but most of these studies did not include those with advanced CKD or ESRD. There was a trial called the CART trial that looked at patients undergoing elective vascular operations, sort of as a surrogate for transplant. And they found that elective preoperative revascularization with stable cardiac symptoms does not significantly alter post-op outcomes. But we accept that first year post-kidney transplant carries a higher risk of MI, and so we need to think about this. So this was the ischemia CKD trial. So this is not specifically dedicated to transplant, but it is the beginning sort of this discussion. So this study looked at invasive versus conservative management of ischemia and CKD. So this was 802 CKD and dialysis patients with an eGFR less than 30 or on dialysis. There were 13% that were on the wait list for transplant, 3 with prior kidney transplant, and they had moderate to severe ischemia on MPS. And they were randomized to PCI within 30 days or CABG versus medical therapy. And they looked at the outcomes of the main outcomes of composite of death, a non-fatal MI over 2.2 years follow-up, and several key secondary outcomes, subcardiovascular outcomes. So if you look here, the primary composite, conservative strategy versus invasive treatment, no difference. And for secondary outcomes as well, there was no difference. And then this study is a retrospective cohort study that looked at almost 80,000 adult first-time kidney transplant patients over 14 years in USRDS. Okay, and the predictor was receipt of non-urgent, invasive or non-invasive, so any sort of test, right? In the 12 months prior to kidney transplant versus not, okay? And they looked at the outcomes of the composite of death or acute MI within 30 days after kidney transplant. And they looked at this rate difference for those who had testing versus not. This is all comers. Here you can see the line here almost touches 0. And for all study periods, except for this 2000 to 2003 period, there was really no difference in post-transplant acute MI occurrence, whether you got screening for coronary heart disease or not. And so, this really begs the question, what do we need to be doing with these patients? And I think what you suggested is probably the right approach. But I don't know, in transplant, the variability between transplant centers to me is mind-boggling. The VA, depending on which, because at the VA, we evaluate them and then they go to a specific transplant center, right? Every transplant center has its own ideas, right? And it's I don't know, it's a source of extreme frustration. So I'll end by saying, let's try to choose wisely in nephrology. I don't know that I've moved us closer to choosing wisely, but I feel like we at least start to think about what we're doing. And there are some things that are in my random access memory that are sort of subcortical that I do every day. I've been doing for years, right? And I forget to stop and think about, why the heck am I doing this, right? And I think it's a healthy exercise to do this. And I like that this Choosing Wisely campaign is reminding us of this, that at the population level, we try to address public health needs, use evidence-based medicines, optimize benefits against harm, minimize costs. But then we take it to the individual patient where we can have conversations about, do I really need this test or procedure? What are the risks and side effects for me? Are there simpler, safer options? What happens if I don't do anything? How much does it cost and will my insurance pay for it? So these are all sort of corollaries of this choosing wise in nephrology and how we take it to the bedside. And I know that you're all in good hands. Thoughts, questions, any other things that you guys think we do for no?
What you do with the patient in equal access?
So with the patient in the equal access clinic, I did an assessment of proteinuria. That's really what we ordered, and he's coming back. And look at that data and go from there. And then, HIV testing, I was able to get that at the health department for free. So, and then we sort of made a plan to sort of build to whatever we need to collect on him, over several visits if he returns. It's a challenge. It really is a challenge. I bring the fellows there and I feel sad because they come in guns blazing. I'm like, no, we can't get that. No, we can't get that. Bayo comes with his ultrasound with the POCUS. And so that's how we've been kind of overcoming imaging, so we do our best.
Let's see, thank you so much for this lecture. I feel like this movement was so prominent maybe 7-10 years ago, and then something has changed. And when I was on service here at Tirapa in January, right, on weekend and during the week, so many patients came in with shortness of breath and they got CTPAs.
Oh, yeah.
And all of these CTPAs show pulmonary edema.
Yeah.
And they got vancomycin and linezolid. And it's like multiple patients.
Yeah.
And at this point, you're like, is this a new movement, just treat everyone the same way?
Yeah.
Or is there still medical decision making that,
No, I know I think it's a fascinating sociological experiment. I mean, I think some PhD in sociology or psychology could do their thesis on this about how these movements happen in medicine. I mean, I see it. David always says his thing about every 20 years, 50% of what we know in medicine changes. I think it's every 10 years. I mean, I attend on general medicine and I swear, I mean, every time I go on, it's just, there's something new. And all the interns and residents say, this is what we do now. I'm like, what? Interns and residents just want to know things. They don't necessarily want to think about things. They just want to know, this is what we do. I hear them teaching the med students. Okay, this is it. What do you do? Presenting with this, what do you do? And I'll stop them like, well, why do we do that? Okay, well, how do you know that? I haven't even thought about it. You know what I mean? It's just sort of what we're doing now, and I feel it. I feel just a culture change every few years when I attend on medicine. And so I mean, if anything, this is just a reminder to me to sort of stay alert and to ask questions and it's okay to make decisions, based on not having a lot of information, but also being aware that we're doing this really based on the data, with the best information we have,
Thank you. It was almost nostalgic to me,
Yeah.
because I feel like it has changed recently.
No, I agree with you. Thanks, guys.
Thank you.